contraindications and complications. Different indications for PAC have been suggested, but routine use of PAC is not recommended. At Fuwai Hospital, the insertion of PAC is patient and procedure indicated. For example, PAC is utilized in patients with impaired heart function or pulmonary hypertension at the discretion of anesthesiologist. For some surgical procedures, such as pulmonary endarterectomy, heart transplantation, PAC is routinely inserted. In 2003, ASA updated the practice guideline for pulmonary artery catheterization, suggesting that the appropriate use of PAC should be based on 3 aspects, namely patient factor, surgery factor, and setting factor. PAC should not be used in patients with right heart-sided endocarditis, tumors, masses. Contraindication related to CVC also apply to PAC insertion. The invasive nature of PAC implies a risk of complications, which could be grouped into 3 types: cannulation-related, insertion-related, and maintenance-related. PAC insertion and setup. This is what we use at Fuwai Hospital. 7.5 French PAC and 8.5 French introducer sheaths. After remove the package, they look like this. Sterile techniques are used when inserting a PAC. Transducer is calibrated beforehand. And in addition to anatomic landmark technique, ultrasound pre-location and real-time guidance techniques are used. As you can see from the picture, 2 punctures were made in the right internal jugular vein. After that, 3 lumen CVC was inserted and the introducer were inserted. The PAC were inserted via the introducer to its position. Introducer and PAC assembly, as shown here. After connecting the distal and proximal port to the transducer, PAC is flushed with heparinized saline to the air, and the balloon integrity was checked. The position of PAC tape is determined by insertion depths, pressure waveforms, and pressure values, as shown here. In this video, my student, Dr. He, performed the PAC insertion till its tape arrived at a pulmonary artery. And if you can hear her well, she reported every 10 centimeter insertion. Right ventricle. Pulmonary artery. You can see it took her 39 seconds. After the PAC is in place, hemodynamic variables can be calculated. Pulmonary artery blood is sampled and blood gas analysis is performed. SVO2 is calibrated in vivo. After completion, SVO2 can be displayed on the screen in real time, as you can see from the left side. As shown here, PAC provides constant measurement of blood temperature, which is an accurate reflection of core body temperature. PAC and patient outcomes. Swan-Ganz catheter may be life-saving in Atlanta, but mostly nuisance in Houston. In 1996, Dr. Kernels and his colleagues reported in the support trial that use of PAC in nearly 6,000 critical ill adult patients was associated with no benefit, but led to increased mortality and resource utilization. After that, Editorials titled such as Swan-Ganz for the Swan-Ganz catheter, Is it time to pull the pulmonary out catheter appeared in leading journals. But don't forget, PAC is just a monitoring device and diagnostic tool, but the patient's outcome can be influenced by many factors. The concerns regarding the limited or no benefits have led to a marked decrease in PAC use. In US, 65% decrease, Canada, more than 50, Australia, same story. Here, I summarize the major trials of PAC on the outcomes of non-surgical patients. This is support trial. As you can see, I marked the outcome in different colors, mortality in yellow, morbidity in blue, and resource utilization in green. In contrary to the support study, all these single center or multi-center randomized control trials did not demonstrate that PAC use will increase the mortality. As far as morbidity is concerned, the findings was mixed. With respect to hospital length of stay, ESCAPE trials and the French trial did not demonstrate that the PAC use will increase the length of stay. Is there still place for Swan-Ganz catheter in cardiovascular surgery? I also summarized the survey and the retrospective studies of PAC use in cardiac surgical patients. For example, according to Brugman 2016, the overall PAC use in cardiac surgical patients in the United States is around 34%, and showed an increase from 2010 to 2014. Another survey of 6,000 SCA members demonstrated that 34% respondents always use PAC, and 45% respondents always use PAC in off-pump coronary artery bypass surgeries. This figure shows the annual cardiac surgical volume and the PAC use ratio at the Fuwa Hospital. As you can see here, the PAC use ratio increased from 7.2% in 2016 to 17.3% in 2019. Recently, my colleague Dr. Xie and I performed a meta-analysis evaluating the effect of PAC use on cardiac surgical patients and non-cardiac surgical patients. 20 trials were included for analysis. And the meta-analysis demonstrated that PAC use did not influence in-hospital mortality in either cardiac surgical patients and non-cardiac surgical patients. And meta-analysis also demonstrated that PAC use did not influence the composite incidence of post-operative morbidities, as shown here. This table shows the meta-analysis results of individual post-operative morbidity. The only positive finding is that PAC use was associated with post-operative pulmonary complications in non-cardiac surgical patients. Post-operative recovery. Meta-analysis suggested that PAC use may increase the hospital cost in non-cardiac surgical patients. Off-pump coronary artery bypass. OPCABG is regarded an alternative to on-pump CABG. It avoids the use of CPB. The first OPCABG was performed by Soviet doctor in 1967, and the first OPCABG in China was performed at Fuwa Hospital in 1996. Several high-quality clinical trials have conducted since OPCABG became popular in the 1990s, which have demonstrated that no benefits of OPCABG over traditional CABG. OPCABG is associated with less effective myocardial revascularization and does not entirely prevent CPB-related complications. Similarly, the retrospective analysis from Fuwa Hospital suggested that compared with conventional CABG, OPCABG is associated with more short-term gain, but increased long-term risk of repeat revascularization and MACE events. Therefore, since 2006, selective and individualized use of off-pump techniques has begun at Fuhai Hospital, and the proportion of off-pump coronary artery bypass decreased in the last decades. As you can see from this slide figure, in 2020, there are 2007 cases of isolated CABG performed at Fuhai Hospital. The off-pump ratio is 52.6%. However, according to Chinese Cardiosurgery Registry, in 2016, 60% of CABG are performed using off-pump techniques. In China, some hospitals achieved 90% of off-pump coronary artery bypass rate. OPCABG present special challenges for both the surgeon and the anesthesiologist. They should work together very closely. Anesthesia management for OPCABG procedures has been well described in previously excellent reviews, as shown here. The challenges of anesthesiologists to manage off-pump coronary artery bypass surgery are greater than when they manage on-pump CABG, but the principle remains the same, namely to maximize myocardial oxygen supply and minimize myocardial oxygen consumption. To do so, perfusion pressure should be maintained. Coronary perfusion pressure equals diastolic blood pressure minus left ventricle and diastolic pressure. LVEDP cannot be directly measured. PCWP measured by PAC can use it as a surrogate. MAP over heart rate ratio is known as Buffington ratio, is very useful index for myocardial ischemia monitoring. Buffington ratio of less than 1.0 will increase the risk of myocardial ischemia. Other monitoring modalities for myocardial ischemia include ECG for ST segment changes, PAC for observation of elevation of pulmonary artery pressures. These two pictures are from the same patient. This is a pulmonary artery pressure. And the TE for segmental or regional wall motion abnormality. Open heart surgery provides a unique challenge, opportunity for us to monitor, visualize the heart directly. Recently, my colleague Dr. Qi and I retrospectively analyzed the PAC effect on patient outcome who undergoing off-pump coronary artery bypass surgery. 1,006 patients were included. They are divided into two groups, non-PAC group and PAC group. After PSM, propensity score matching, we got nearly 400 pairs. Their baseline characteristics are comparable. Their intraoperative data are similar. Their post-mobility and mortality is no different. But PAC use might increase the hospitalized expenditure. To sum up, many technologies seek to supplement PAC, especially after supported trials. But none of them has been subjected to as much clinical use and scrutiny as PAC. PAC remains gold standard for many measurements, such as cardiac output, SVO2, etc. And other alternative monitors cannot measure PCWP. The happiest people don't have the best of everything. They just make the best of everything they have. From 1970, the research enthusiasm increased steadily until 1996, when support trial was published. Is the Swan dead? The answer is definitely no. Swan-Ganz has come to a full circle. It is devised by two cardiologists to probe the working of the heart. It has inspired clinical use and research. Evidence has developed that harm could result if it is not used properly. PAC is a cornerstone of critical care medicine. It brought new knowledges. It is stimulus to new technology, devices, and evidence-based medicine. It remains a gold standard measurement for cardiac output, SVO2, blood temperature. Don't forget, it provides these data in one piece. PAC is also a very simple bedside tool with proven utility. 20 years has passed since ASA published its guidelines for PAC. New evidence has accumulated, and many doctors have get experience with PAC use. In order to maximize the benefits of PAC use, mitigate the harm, and minimize the complication of PAC, a lot of work needs to be done in the future. Thoughtful patient selection, judicious use of the device, and many evidence gaps need to be filled. Actually, OPCAB and PAC share some similarities. They have experienced similar popularity trends. Their current utilization is greatly varied among different centers. Their effects on patients' outcome remains controversial. Also, their routine use are not recommended, but PAC remains a gold standard. OPCAB is an important alternative. And they also face the same challenges in the future. When PAC use and OPCAB use going down, how the future generation of surgeons and physicians get themselves familiar with these techniques remains to be addressed. Chinese philosopher Confucius reviewed his whole life by saying that, here I quote, "When I was 50, I knew what was pre-decided by fate was not within my reach. When I was 60, I was able to accept opinions of various kinds." PAC has a history of 52 years. OPCAB has a history of 55 years. They are ready to accept opinions of various kinds. Recommendation readings. As requested, there are 3 quiz questions for the audience. The first one, how many PAC have you ever inserted? A, nil. B, 1 to 50. C, 51 to 100. D, more than 100. David, should I pause here?
Yes. Yeah, Dr. Jiang, Dr. Yao.
Okay.
Yeah. So the participants.
I will try to answer it. Yeah. For my own experience, the totally PAC I performed by myself is more than 100, I think. But for the students who are and the residents, I supervise probably double or triple this number. So totally probably more than 300, I think. Thank you.
So we saw a response from Dr. Wang Jianguo. His answer is 1 to 50. Also, we have more than 100 as well from India. Yeah.
Yeah, you can check the answer from our chat box. Yes, a few participants are responding. Okay, D.
Can I speak?
So far we have 2D. Yeah. Please go ahead.
David, it was a very interesting talk, Dr. Jiang. I'm sorry if I don't pronounce your name correctly. My apologies. It was a very interesting talk. I was listening very intently. Yes, my middle name is PAC. So I don't know, I don't recall because I've been putting PAC for the last 20 years. So we do it every day. Maybe I don't have a count, but it would be easily more than thousands. So Well, yes. So I would say more than 1,000.
Okay, that's a very big number. Thank you. Thank you, Dr. Rajesh.
Should I
Okay.
continue?
Anybody else would like to answer this question? Or maybe you can, Dr. Yao, would you please ask the second question?
Okay. Question number 2.
Yeah.
How often do you use PAC in cardiac surgical patients? A, always 100%. B, usually more than 50%. C, rarely less than 20%. D, never 0.
May I answer your question first?
Sure.
Okay. Yeah. Thank you. For my working experience, my number probably between the 50% and 20%. So it's usually, but not more than half, I think.
Okay. Your answer is B minus C plus.
Yes, thank you. But in my hospital, we do lots of organ transplantations. Sometimes the liver transplant, we prefer to use the PAC, but we afraid of the hemorrhage, so sometimes for the liver transplant, the rate is above 50%, I think. Not only in cardiac surgery. In transplant, we use more than half. Thank you.
I think we have a question from Dr. Wang Tao. Yeah. So Dr. Wang Tao was asking, have you ever come across any severe complication related to PAC?
My personal experience, no. You know, as I mentioned before, quantity determines quality. Practice makes perfect.
Okay, thank you.
David, may I?
Yes, please.
Yeah, please go ahead.
I agree with Dr. Jiang. I have never really seen, because it's not personal, but mine and my colleagues. So last 20 years in my center where I have worked in 2-3 high volume centers, I have not seen any serious or life-threatening complication arising out of PAC. So, and that number will go more than many thousands, because it's like more than 10 hours running every day. That will be a very high number. I'll not go into numbers, but I don't believe serious life-threatening complications can happen in a trained hand.
Okay. Yeah. Thanks so much, Dr. Rajesh. Maybe we can move on in the interest of time.
Question number 3. How often do you use PAC in off-pump coronary artery bypass surgery? A, always. B, usually. C, rarely. D, never.
Okay. In my hospital, most of the off-pump CABG is performed by minimum invasive. So in that case, if more than three branches or 3 bridges, we will use the PAC. Otherwise, we only use TE. For the traditional thyroidectomy surgeries, for my experience, I always use PAC in that kind of surgery. So it's different. Thank you.
Yeah, I see we got some response from the chat box too. Some clinicians never use, some clinicians more than 50%. Yeah, it's very interesting feedback. And
thank you, Ms. Meng.
I have a comment with the permission of Mr. Mod. I can speak?
Yes, please, Dr. Rajesh.
Okay, so I would always like to use PAC in off pump. In fact, I'll go on to say that if we use PAC, we can perform OPCAB in we can extend the spectrum of off pump coronary artery surgery. The CABG, the PAC is complementary. Like again, in my centers, off pump cardiac surgery was the rule. on-pump coronary surgery was the exception. So PAC allowed us to do that journey, that we were universally doing off-pump coronary only. PAC made it possible. Thank you.
Thank you. May I ask Dr. Yang one question?
Sure, please.
Okay.
Dr. Yang.
For the off-pump CABG, the ratio between TE and the PAC in your hospital, how much?
Oh, okay. As we all know that TE and PAC are complementary tools to each other. At our hospital, TE is not that often used, but I know that Dr. Jiang is very experienced in TE, especially in intraoperative TE.
Thank you.
And I know the hospital you work, Zenmin Hospital, has a large volume of off-pump coronary artery bypass, especially in Beijing.
Yeah. Thank you. Thank you very much.
Thank you.
Okay. Anybody else has any questions?
Dr. Jiang, for the interest of time, I think we can move forward for next presenter. Yeah.
Okay. Thank you, Dr. Yao Yuntai. It's very wonderful and comprehensive presentation. Now let's welcome the second presenter, who from the Peking Engine Hospital, and let's introduce him. Dr. Hou Yuxi, graduated from the Peking University Medical School, and now working at the Capital Medical Hospital, Capital Medical University affiliated hospital, which is the second big cardiovascular center in the whole world. He is an attending doctor who had around 10 years experience in cardiovascular surgery and seizure. So now let's get a warm welcome to Dr. Hou Yuxi. Thank you. Dr. Hou, could you?
Yeah, Dr. Hou, we can see your screen just now.
Yeah,
we can see your presentation.
Yeah. Thank you, Dr. Jiang. I'm appreciate the opportunity to be invited today, and my presentation concerns Swan-Ganz is important for anesthesia management of left ventricular assist device inserting. This is a brief introduction to my hospital, but as the time is limited, so now I'd like to move on to the main subject. My presentation is divided into 6 parts. Key point: medical records for admission, diagnosis, examination, intraoperative management, and outcomes. First, the equipment we used was HeartMate 3 from Abbott to the patient. So firstly, let's review the medical record for patient's admission. The patient is male, 64 years old. His body surface is 1.87 square meters. He was admitted on November 8th, and after finish perioperative examination in 2 days, he accepted the surgery. He was diagnosed with dilated cardiomyopathy, stage 4 heart failure, mitral valve regurgitation, tricuspid valve regurgitation, arterial fibrillation, left bundle branch block, stage 2 hypertension, high risk, and type 2 diabetes. Here are some basic examinations before surgery. The NT-pro is significantly increased, and the other blood tests are nearly normal. And the chest X-ray reveals the cardiac enlargement. The ECG shows the rhythm is atrial fibrillation, and the ventricular heart rate is 115 beats per minute. The assessment of right ventricular function is vital for the procedure. So every patient needs echocardiology and the right heart catheter in my hospital before surgery. The echocardiography shows his ejection fraction is 20%. He also had severe mitral and tricuspid valve insufficiency. The pressure, PG is 24 milliliters of mercury, and the systolic pulmonary artery pressure is 44, and the TAPSE TAPS is 13 milliliters, which reveals the contraction function of right ventricular. And the result of right catheter is more accurate and important. The pulmonary capillary wage pressure is 5 millimeter per mercury, and the right ventricular pressure is 11, and the CVP is 6 milliliters per mercury, and the PVR, which stands for the pulmonary vascular resistance, is 6.8 volts, which is acceptable resistant for the whole surgery. And we also do coronary angiogram, which shows the obstruction of coronary artery is mild to moderate. According to the perioperative examination, the patient was expected to take left ventricular assist device inserting and mitral valve plastic surgery, tricuspid valve plastic surgery, and artery fibrillation ablation. Then there are some special monitorings are essential for this surgery, such as TE and Swan-Ganz, and arterial blood gas analysis should also be done before the induction to examine the patient's internal environment, because the patient is in end stage. Because these end-stage patients, acidosis reduce the effect of vasoactive drugs, especially in this kind of patients. For patients with severe heart disease, in our center, we tend to choose etomidate as sedative and a high dose of Seventel as analgesic. And we also try to avoid midazolam because the combination of Seventel and the midazolam has strong cardiovascular inhibit effect. According to the pathophysiological feature, this patient, we use dopamine and to maintain the blood pressure and heart rate. And after the induction, the blood pressure and heart rate is acceptable. When the patients after the extracorporeal circulation, the assist device began to work. We need some vasoactive agent to achieve optimal hemodynamics. In this case, we chose norepinephrine and hypophysin and to keep the resistance of the systematic blood pressure. And we also chose dobutamine and mironone to enhance the right heart function. And we also inhale nitric oxide to reduce pulmonary hypertension. When the patients left the operating room, all the indicators were satisfied and the patient is in really good condition. As we can see, the blood pressure is 77 and to 71 millimeter per mercury, and heart rate beats is 99 beats per minute. It's a pacemaker rhythm because we did the ablation during the surgery. And the pulmonary artery pressure is a little bit higher. It's 33 to 16 millimeters per mercury. And the SpO2 is 89%. And the CVP is also good. And the lactic acid is low, is 1.8. And as a result, the prognosis was good. The patients extubated 1 day after the surgery and stays in the internal intensive unit for only 4 days. Next, I will summarize the key point of anesthesia in left ventricular assist device inserting surgery. The most important thing is the pre-anesthetic assessment. It is very important for every patient should check ultrasonic echocardiography before the surgery and the right heart catheterization before the surgery. If some patients may insert Swan-Ganz catheter before the surgery, and it is also very important. And it can replace right heart catheterization. So in this kind of patient, we should focus on the right heart function. We need, which includes the pulmonary vascular resistance, mean pulmonary artery pressure, and right ventricular ejection fraction, and the right ventricular stroke work. And in some patients, especially caused by ischemic heart disease, we should also focus on the patency rate of right coronary artery. During the surgery, there are some special monitoring that is needed. Both T and Swan-Ganz is important. We use Swan-Ganz to monitoring the pulmonary pressure, and we use T during the surgery to see if the pump is at the right position. The important thing is the blood gas analysis before induction is important. During the end-stage heart failure patients, the maintenance of sympathetic tension is also needed. Next, let's see a picture. This picture reveals the blood from mitral valve flows into the device and pump out directly into ascending aorta after the surgery. So the ejection function of left ventricular is decided by the pump. Determinant of blood pressure are only preload and systematic circulation resistance. Only these two can decide the blood pressure. Mixed venous. So how to see if the preload is adequate? The mixed venous, the SpO2 and the urea volume and the lactic acid can reflect the preload. If the SpO2 and the urea volume reduces and lactic acid increases, it reflects insufficient preload. which might cause intravenous septum suck down. It's a very serious side effect, can cause early death of this kind of patient. And if the SpO2 rises and the lactic acid is lower and the urea volume is also rises, which means the patients might be in overload. And the overload can also cause right heart failure during the surgery, which is also a side effect, risk to the patients after surgery. Then the SVR is maintained by the vasoactives. We also use these kind of two drugs to maintain the resistance during the surgery. At last, maintaining the stability of pulmonary circulation is more challenging because the right heart failure occurs 15 to 25% after the LVAD inserting, and nearly 4% need the right ventricular assisted device inserting. The right heart failure may be caused by left cardiac function improved. Then the cardiac preload of the heart increases. And some other scholars suggest right heart failure may be caused by imbalanced interventricular septum movement. To prevent severe right heart failure, the management targets are keeping suitable preload, maintaining central venous pressure between 8 to 12 millimeter of mercury, and proper heart rate, sinus better, or pacemaker rhythm. The heart rate should be 80 to 100 beats per minute, and the lower pulmonary artery pressure and adequate right ventricular function. The right ventricular ejection fraction should more than 30%. To achieve that goal, we need the help of several drugs, as we can see from this chart. If we need the right ventricular preload lower, we can use diuretics or hemofiltrations. And if we need to lower the right ventricular afterload, we can use pulmonary vasodilators, as we also use Mironol and NO as to reduce the pulmonary vascular resistance. And if we need the right ventricular contraction to rise, we often use Mironol and dopamine. And the rhythm is also very important. As I said before, the sinus rhythm is better, but if we don't have sinus rhythm, we better use the pacemaker rhythm. So here is my question. Which interpulse for right ventricular do you prefer? Mironol, dopamine, or combination of the two drugs?
Maybe this question is for me to answer first. Okay, Dr. Hou. From my experience, there is only one can use for the right ventricle dysfunction, which do not decreasing the blood pressure, the systematic blood pressure, is a dupilumab. And for the Mironol, we have to use combined with norepinephrine. Otherwise, the systematic blood pressure will be dropped down severely. So that's my answer. Thank you.
Thank you, Dr. Jiang.
So, Dr. Yao, could you please answer this question?
Dr. Ho, do you mind sharing your screen again? Sorry.
Yeah.
Yeah, thank you so much.
I will choose dobutamine. I personally seldomly use milrinone because according to evidence medicine, milrinone is associated with long-term mortality and morbidity in patients. And it is a drug. It is an agent with multiple functions, such as inotropic, vasodilators. I cannot trust a drug with so many functions in one patient. I will choose dobutamine.
Very good reason. Very good.
May I?
Yes, please.
In this setting, in the patient setting of LVAD, I would use both, because dobutamine and milrinone, because especially if we see this patient had TR also, so right ventricular function may be a question mark. In this situation, the one agent may not be enough. So we may need to use these two and a high dose of nitric oxide. And to support that, we may need to use some vasopressin for SVR. But yes, for this setting, my guess is I would definitely use both with high dose of nitric oxide. Thank you.
Thank you. Thank you very much. So, Dr. Ho, would you please to ask this question number 2?
No, just one question.
Okay, good.
Okay.
May I ask one question, Dr. Ho?
Please. Yes.
I noticed that you don't give us the left ventricle inner diameter in your echocardiography parameters. How big this left ventricle were?
Let me check. Is 56 milliliters.
56? 56 is
56.
just above the normal. 50?
Yes, it's it's nearly normal.
Okay,
it's
so
not as big as we thought.
It's not very routine in DCM.
In this kind of patient, yes.
No. Okay, so you put the left ventricle assistance device into people who only had the right ventricle dysfunction. I think his left function is okay.
Yes, so this patient, the right ventricular function is okay.
Okay. Why would you just put the right ventricle assistance device to these patients?
Oh, because the left ventricular is assist with the equipment after the surgery, so we don't have to consider the function of the left ventricular. We just have to keep the SVR right after the surgery to keep suitable blood pressure.
Okay.
So we use now some medicines. Yeah.
Yes. How much about the CI, the cardiac index, before and after the device put in?
The CI of this patient is decided by the equipment. The CI, we just see the CO is 4.12.
Before, how about before procedure?
Before the procedure, the CI is, I think I didn't have a picture. Before surgery, the CI is 1.2.
1.2.
After induction. Yeah.
Okay. Okay. And there's a tap.
So I use dopamine. To keep the heartbeat and to keep the blood pressure after the induction.
The reason in that time is sinus or still AF?
After AF.
AF.
After the induction is AF.
Before is AF already? Before surgery is AF?
Before,
or...
yes.
Okay.
But before surgery is AF. Is also AF. Is a long time. Long air.
Can I ask one question to Dr. Yao?
Sure.
Yeah, for this kind of patient, would you, in your hospital, would you put a CRT first of all, or you just keep it like an AF or something like, or some recent treatment?
No,
CRT.
We don't put CRT.
Okay.
Can I ask a question?
Yeah.
Dr. Jiang, this is a question about inotropic and vasoactive agents for all doctors, for Dr. Jiang, Dr. Ho, and Dr. Rajesh. According to a nationwide survey by the Chinese Society of Cardiovascular Anesthesiology, dopamine is the most common used inotropic in China, but which is in very contrast to conditions in North America and Europe. I'd like to ask your opinions about how to select the inotropic and vasoactive agent. And for example, according to the survey, vasopressin is the most commonly used vasopressors in liver transplantation surgeries. You mentioned, Dr. Jiang, that you have a lot of liver transplantations.
Yes.
And for Dr. Rajesh, do Indian colleagues use dopamine very often, intraoperatively and postoperatively? Thank you.
May I?
Yes, please.
You really opened the hornet's nest, because the choice of inotrope, it could be end into a pro and con debate, very big debate. I'll make it short. In India, we are almost evenly divided with dopamine, and there are followers of dopamine, and then there are people who would use epinephrine and norepinephrine and dovitamin. At the risk of, I don't have the time and evidence right now to put it, but I don't think the choice of particular antibiotic drug will will control our outcome. It is our capability to handle the inotropes we choose judiciously in those patients, combined with other things which are going to determine outcome, because there are no studies world over which will show any outcome difference with choice of antibiotics. So I would rather say we should use what we are used to using, and we can get our desired out. We can use our ingredients. Outcome we will determine. Thank you.
Okay. For my answer, for the people who had the right ventricle dysfunction, the dobutamine is much more better than dopamine. I normally, for that kind of patient, I will check the TAPC first of all, because the TAPC is a very sensitive parameter to the right ventricle systolic function, which is quite easy. You can get from the TTE or TE. For that kind of patient who had the TAPC below 16, I will just choose dopamine and the norepinephrine together.
Okay, thank you.
And for the hepatic cardiomyopathy, for the patient who always found in that kind of liver transplant, is other kind of situations. For that kind of people who had very severe shunts between the right and the left hearts in the pulmonary system, so we use norepinephrine to close that shunts, to increasing the oxygen transfusion, and we sometimes use a little dosage of the dopamine, just for in case, not for protection, just for in case left, or in case for the hemorrhage, for the blood loss, something like that. Thank you. Thank you very much.
Thank you.
With permission of chair, I have two quick comments. One is, sir, the TAPC is a good way of seeing RV dysfunction, but post-operatively in all patients, TAPC will be down. So it may not be a very good indicator. We will have to look at other, yes, thank you. And other matters of RV dysfunction. Other was about my colleague, his experience with LVAD. I just want to use the word of caution, because SVO2 is an indicator of volume, but we have to be careful, because if our oxygenation, because of any other lung reason, oxygenation is not good, it will confound that SVO2. And in post-operative day 2, day 3, if there is sepsis, this also tends to confound. So that is something which needs to be carefully observed. Thank you, sir.
Okay. So I know what you mean. The TAPSE is quite a limited parameter for the right ventricle because it only measures 1 point in the lateral wall of the right ventricle. Because the right ventricle is very complex of shapes, volume. It's hardly to use the EF or the TAPSE or the only one parameter to measure the whole right ventricle function. We have to use both of them together. Thank you. Okay. Do you agree? Do you guys agree with me?
I think in the interest of time, I think we...
Yes, please. Yeah. So we are going to introduce the third presenter who come from Taiwan. I'd like to open the CV. It's from, sorry about my mouth. Can you just play the video? I will introduce her later. Okay. David.
Yeah,
David,
sure.
you
Absolutely. Yeah.
Please, please.
Can you hear the video?
Yes, I can.
Yeah. Okay. It's playing now.
Did a large study about OPCABG patients. They had a long-term follow-up. And we can see that 50% of their OPCABG patients have cognitive dysfunction immediately after the surgery. And furthermore, those who had immediate decline at discharge had poor long-term cognitive dysfunction 5 years after the surgery. And in other study for TAVI, they did a preoperative MRI and postoperative MRI after the TAVI. And there's a shocking evidence. We can see for the patients who had TAVI, neurocerebral infarcts occurred in 77% of the patients. And furthermore, 2 of the patients have stroke. So neurological injury after cardiac surgery is a serious issue. Stroke occurred in 2 to 3% after the operation, and delirium occurred in 25 to 35% after cardiac surgery. And for POCD, 50% to 70% of the patients had this dysfunction after discharge. And for the long-term follow-up at 1 year after the surgery, still 20 to 40% of the patients have the problem of POCD. So what are the neurocognitive dysfunctions we talk about? In 1887 British Medical Journal, there's a description about insanity following the use of anesthetics in the operations, which might imply neurocognitive dysfunction. There's a timeline for which differentiates delirium and POCD. And delirium has been incorporated into a psychological diagnostic criteria DSM-5. So it's easy for us to make a delirium diagnosis by a well-structured flow chart. In intubated patients, we can use the CAM ICU flow chart to diagnose patients who had a delirium. And for those who has been extubated or non-intubated, we can do 3D CAM flow diagram to find out the patient who had a delirium after the operation. But for POCD, it's more complicated. There is no single neuropsychological test that is accepted by all the study population. The POCD could comprise memory, attention, visual spatial perception, language, and motor performance. So it's more complicated, and people can decline in either of the aspects after the operations. And for the classification, we should know what we mean by what we mentioned by the names. And if the patients have postoperative conscious change less than 7 days within the index surgery, it's called postoperative delirium. If the neurocognitive dysfunction is lasted to 7 to 30 days, it's called delayed neurocognitive recovery. And if the patient still is troubled by neurocognitive dysfunction 1 month to 1 year after the surgery, it's called neurocognitive disorder. Here is a summary of the neurocognitive disorder that we just mentioned. So we can see acutely after the surgery is called delirium. And if the neurocognitive dysfunction lasted to days to months, it's called the delayed neurocognitive recovery. And if the neurocognitive disorder persisted after 1 month to years, it's called POCD. So what's the pathophysiology of neurocognitive dysfunctions? There are 4 major hypotheses. The first is aberrant oxidative stress, and the second is hypothalamic pituitary adrenal axis alteration. There is pro-inflammatory cytokine release after the surgery, so there is alteration in this axis which causes neurocognitive dysfunction. And there is evidence of perioperative neuroinflammation because in patients who just had cardiac surgery, if we do CSF tapping, we can see there's increasing inflammatory markers in their CSF. And furthermore, there's another hypothesis that these patients are prone to have POCD because they are already candidates for Alzheimer's disease, and the surgery accelerates the disease progression. So here is a summary of the interaction between 4 different hypotheses. There's neuroinflammation and cytokine release. However, it's not helpful for the practical practice. So clinical practice, so we need to know exactly the risk factors of neurocognitive disorder after cardiac surgery so we can do some preventions. However, there's the only strong evidence for POCD incidence. Increased POCD incidence is the old age, lower educational status, and previous stroke or POCD at hospital discharge. These factors are not changeable when the patient comes to us for pre-anesthetic visits. We cannot change their age, and we cannot ask them to read more books. And if they already have stroke, it's heaven. All other risk factors are not well established because some of them because the study is too small, and some have controversial results in different studies. Here we are going to talk about these factors one by one. The first is cerebral embolism. It's logical for us to think if the patient has more embolism, it's going to have higher risk of POCD, but the study tells us it's controversial. We know if the patient had higher atherosclerosis burden, which is very common in cardiac surgery patients, there's evidence of increased perioperative embolic burden noticed by TCD during the operation, yes. However, if we do a study about atherosclerosis burden and CABG, we can see 6 weeks after the CABG surgery, the POCD is not higher in patients who had a higher atherosclerosis burden. And with the technology improvement, we now have MRI to detect small anatomical lesions like the ones we did for the TAVI patients. Yes, if there's new ischemic change, the POCD is higher 6 weeks after cardiac surgery, which means the anatomical lesion is really meant for something. However, 3 months after the cardiac surgery, the POCD incidence return to normal, even if there is a new ischemic change immediately after the surgery. So we know our brain has some preservations. The anatomical lesions, the emboli, if it's not stuck in some important brain region, it may not reflect the clinical pathology as we can see from these controversial results. And the other factors we like to talk a lot is about hypoperfusion. Whether intraoperative hypotension is associated with POCD has lots of studies, and some say yes and some say no. Before, many of the study differentiate the 2 groups into high MAP or a lower MAP, but many studies show there is no difference in the neurological injury or postoperative cognitive outcomes. So controlling the mean arterial pressure seems not to be very effective to reduce POCD after cardiac surgery. But nowadays we have newer tools. We can monitor brain perfusion by near-infrared spectroscope, SJO2 or TCD, and we can monitor the brain function by BEAS, EEG or SSEP. So now we can know our brain better during the perioperative period. With the NIRS and arterial pressure, we can now calculate the autoregulation of our brain and actually lower a limit of the autoregulation and MAP difference, and could tell the longer our mean arterial pressure is lower than the lower limit of autoregulation, their stroke rate is higher after the cardiac surgery. Here's the large study in JTCVS. We can see the MAP below the lower limit of the lower limit of the autoregulation. It will increase the morbidity or mortality after the cardiac surgery. So for the physiological endpoint for BP management, we should try to keep our MAP higher than the lower limit of the autoregulation to optimize our organ perfusion and improve patient outcome. And what if we keep our MAP as high as possible? It is also not very good in the cardiac surgery, because hyperperfusion of the brain will increase the delirium after the cardiac surgery. So the MAP above the upper limit of autoregulation is also not suggested. And individualize the MAP target in the cardiac surgery is very important. Therefore, we can see in the cardiopulmonary bypass guidelines, assess the adequacy of pump flow rate is a class 2A recommendation to use nurse for guidance. And nurse-guided algorithm to improve cardiac surgical outcome is a 2B recommendation in the 2019 guidelines of cardiopulmonary bypass. And there is some risk factors that we cannot change or we cannot control. If the patient has CRP minor allele, there is a higher incidence of postoperative stroke. And whether cardiopulmonary bypass itself will lead to POCD after the cardiac surgery. Well, there's animal studies and human studies. In animal studies, we use rat, and which we do a cardiopulmonary bypass in the rat, and we do sham operation and compare to the control. We can see a cardiopulmonary bypass did increase the IL-6 or NF-kappa B after the cardiopulmonary bypass. And surprisingly, there is positive evidence of increased inflammation by these biomarkers, yes. However, there's no evidence of its correlation with POCD. What about the data in human? Luckily, we have a large trial called the Ruby trial. It's very famous. It's compare the 10-year outcomes of off-pump and on-pump CABG in the Department of Veteran Affairs in the United States. And the study is published in JAMA Surgery. 1 year after the study started, they did a follow-up for neurocognitive dysfunctions, and they found there's no difference for global cognitive outcome measures for patients receiving on-pump versus off-pump CABG. Therefore, whether POCD is associated with cardiopulmonary bypass, there is not enough evidence to say yes. So we should not choose the cardiopulmonary bypass by the neurocognitive so we should not try to avoid a neurocognitive dysfunction by avoiding cardiopulmonary bypass. We should choose cardiopulmonary bypass by the surgical need. And there's other risk factors or other issues concerning are going to be effective to the POCD occurrence. The other thing is anemia. If we have a extreme hemodilution, which means that if we dilute our hematocrit to 15 to 18 during a cardiopulmonary bypass, it is associated with cognitive decline in pediatric groups and elderly groups. So we should be alert to check the hematocrit, not to lower it to the extreme hemodilution level. And the other risk factors we like to talk about is hyperglycemia. There is evidence of hyperglycemia, which is associated with 6 weeks after the surgery. The cognitive index is lower in diabetic in hyperglycemic patients 6 weeks after the cardiac surgery. However, if we try to control the hyperglycemia during cardiac bypass, we fail to improve the neurological or neurobehavioral outcomes in DM patients undergoing CABG. So whether the sugar control so we all agree that sugar control is important during the cardiac surgery, but whether the sugar level in the blood is associated with neurocognitive outcomes is still not certain. Here we are going to talk about the other risk factor. It's called temperature. So during the pulmonary bypass, if we want to rewarm the patient, it is suggested that we should control the rewarming rate. We should control the nasopharyngeal temperature and the cardiopulmonary bypass perfusion temperature less than 2 degrees, because larger temperature gap is going to cause more bubbles, and more bubbles is going to logically is going to lead to more cerebral embolic load, which might be harmful to the postoperative neurocognitive outcomes. And furthermore, we should avoid postoperative hyperthermia, because in a large study consisting 300 CABG patients, neurocognitive outcome, the cognitive score 6 weeks after surgery is worse in patients who had postoperative hyperthermia. And hopefully, let's talk about some pharmacology. Is there a single agent that's used and could prevent POCD? Well, there's no strong evidence till now. There's a study of unpumped cardiac surgery comparing propofol to sevoflurane, which showed that the sevoflurane might be beneficial in short-term postoperative cognitive performance. However, the study only consisted of 128 patients, which is very small. So it is not accepted as a guideline for the clinical practice. Other studies proposed ketamine infusion during the induction, and they said the study showed that ketamine low-dose infusion could lower the postoperative CRP, which is an inflammation marker. It also attenuates POCD 1 week after cardiac surgery. But we can see here that the study group is also very small. It consists of 26 ketamine group and 26 placebo group. So the evidence is not strong enough for us to change our clinical practice. And in addition to the anesthetic drugs, there is a study doing high-dose lidocaine infusion, and they want to see if the high dose of lidocaine, which could pass the blood-brain barrier, could lower POCD. However, higher dose of lidocaine infusion and diabetes status were independent predictors of cognitive decline 6 weeks after the cardiac surgery. But they found lower dose of lidocaine might be beneficial. So there is a clinical trial doing a low-dose lidocaine infusion in non-diabetic subjects, and a registration trial number is listed below in this PowerPoint. So the data is not published, so let's see what they are going to tell us afterwards. So from previous introduction, we can see there are so many risk factors which could lead to POCD or postoperative neurocognitive dysfunction. So how should we prevent perioperative neurocognitive disorders in cardiac surgery? We can see here, this is a summary from our anesthetic textbook Miller. There's autoregulation in our brain, and we want to keep it normal during the cardiac surgery. And anesthetic drugs could change the upper and lower limits of the autoregulation. And for the cerebral blood, our blood vessel diameter and flow could be affected by neurogenic control, cardiovascular function, myogenic autoregulation, neurovascular coupling, and vascular reactivity. So we need to adjust our clinical practice to maintain adequate cerebral flow to have the best neurocognitive outcomes after the cardiac surgery. So we should address the issues concerning the cerebral desaturation. So if there's a cerebral desaturation, we need to check if there's any mechanical obstruction. So we need to check if the head position is neutral and the heart position is okay. and if they have cardiopulmonary bypass, or if it's like DAA surgery, they have selective cerebral perfusion, we need to check if there's arterial obstruction or cannula malposition. Second, we need to check if there's cerebral desaturation, if there's adequate oxygen supply. We need to check our ventilator and see if the oxygen fraction is okay. If there's adequate hemoglobin, we don't want to have extreme hemodilution during a cardiopulmonary bypass. And in cardiac and neurological patients or older patients, we might want to have a higher HB to fasten our oxygen delivery. And the third one is we need to check the mean arterial pressure. If we have used near-infrared spectroscope, we should keep our mean arterial pressure between the limits of the autoregulation, because higher MAP over upper limit will cause higher incidence of delirium after the surgery, and lower limit and lower MAP lower than the lower limit of autoregulation will cause organ dysfunction and has higher morbidity and mortality after the surgery. And we need to check the patient's cardiac output. And if it's already on bypass, we need to check the pump flow. And because the arterial carbon dioxide concentration could affect the vasogenity of the cerebral blood vessel. So if the CO2 is high, the vessel tend to dilate, and if the CO2 is washed out, it tend to constrict. So if we want to deliver adequate blood flow to our brain, we need to adjust the adequate CO2 level during anesthesia. And after we check the oxygen delivery, we need to check for the oxygen demand. If the patient had higher blood temperature, if it's fever, the oxygen demand will increase. And if the anesthetic level is too low, so the patient is awake during the surgery, the oxygen demand is high. And if the patient is in pain or the patient had a seizure attack, the oxygen demand of the brain will all be increased. And we need to address this issue during the operation to optimize the metabolic demands during the cardiac surgery. So here is my introduction to the postoperative neurocognitive issues in the cardiac surgery, and thanks for your
Thank you, Dr. Wang. May I just introduce Dr. Wang? She is from the Taiwan University Hospital, Yunlin campus, and she finished her residency in University of Rochester School of Medicine. Okay, now let's welcome the third, the fourth presenter.
Professor Jiang, before we move forward to next speaker, may I have a question based on the Dr. Wang's presentation?
She's online now?
No, she's not online. I just want to ask a question about your and the other speakers' opinions based on Dr. Wang's presentation.
Okay.
Okay. Yeah, my question is, what's the strategy in your institution? Personally, how to manage and protect the patients, neurocognitive disorder during and after the cardiac surgery?
Okay. My hospital is like a gambling. To be honest, it's like gambling. So we sometimes use nurse, but in China, the nurse is not including in the insurance. It's quite expensive and just deposable. It's probably more than 3,000 for a pair of electrodes. So we have to reuse it. So the signal is just awful. So we do use a nurse, but it's really like a gambling, So we do not have too much strategies or methods to protect that. We try to improve the MAP. We try to increasing the oxygen supply, but just as Dr. Wang said, it's not clear relationship between that. I think the mainly reason for that, people who pretend to have the the trait to become PND is mainly their individual reasons. So we do not have too much method to do that. Thank you.
Okay, sounds like we have a lot of room can work with your
Dr.
doctors to
Rajesh,
improve.
Please.
I'm happy to hear you say gambling, because this is what we also do, because we do all the good things like good good pressure, but it is like we are working unaudited. We are not able to audit it. We are right, because costs are high and individuals are paying. It is not insurance. It is people pay from their pocket, and it is expensive. So we use less. We reuse. Yes. It's a public-private admission that I reuse. The only problem with reuse that these are such sensitive monitors that reuse will decrease their sensitivity, and the numbers which we read, that meaning may be lost. So it's a gamble. Yes, thank you.
Thank you very much. Very honest. Very honest.
Yeah. Since we just launched the platform with the cerebral oximetry as well, so maybe you can work closely to figure out how to address the practical challenge from your institution.
First of all, you have to suggest to the government put that cost into the medical insurance. That's the first thing you have to do.
Yeah, we'll try. We'll try our best.
Too expensive for the people.
That may be a good idea to convince the governments or maybe the society. If society will ask for it, because society doesn't ask for it. Society asks me, why are they paying so much? If society asks us for this, then we'll be bound to provide it. Thank you.
Good point.
Thank you very much.
Okay. Yeah, Dr. Jiang. Yeah, you can manage the.
Okay, let's introduce the first presenter, Dr. Rajesh Kumar Chand, who from India. He is serving as a director of cardiac anesthesia and the critical care unit in Max Super Specialty Hospital in New Delhi, India. Now let's have a warm welcome to Dr. Rajesh to have your presentation. Thank you.
Can you see my slides, and am I audible?
Yes, we can hear you and see your slides.
Yeah.
Yes, thank you.
So good morning again, and first of all, I would like to thank Edward for inviting me at this exchange. And I really feel honored and privileged by interaction, because we have been interacting with American and European people, but this is for the first time I'm interacting with from the land of ancient and wise culture, China. So I really feel privileged, and so I'll proceed with my talk. We have already discussed a lot about Swan-Ganz, its use in off-pump surgery, LVAD, neurocognitive. I would try to, Swan-Ganz has been used largely in surgical setting. So I would like to just talk about the possibilities and usage of Swan-Ganz in the right ventricular dysfunction, pulmonary hypertension, and cardiogenic shock. This is my hospital. We are a private hospital. We have reasonably good facilities, but we are prohibitively expensive. I am ashamed of that expensive part. I'm proud of our capabilities, but my cost makes me ashamed of myself. So I'll proceed with my talk further. I'm sorry. So this is the overview of my talk today. I would talk a bit about cardiogenic shock, the use of Swan-Ganz in cardiogenic shock, historical evidence. I will talk slightly about the challenges and limitation of non-invasive and minimal invasive monitoring in cardiogenic shock. Then, very interestingly, there is a re-emergence of Swan-Ganz use in cardiogenic shock. So I will try to focus the role of Swan-Ganz and look at evidence, and then I will conclude my discussion. Cardiogenic shock refers to a multiple facet clinical scenario, which is characterized by primarily myocardial dysfunction, inadequate tissue perfusion. This myocardial dysfunction leads to inadequate tissue perfusion in time, and then slowly an irreversible progressive multi-organ failure occurs. And this complicates up to 30%, 13% of acute coronary syndromes. But lately, with increasing burden of coronary congestive heart failure, cardiogenic shock is increasingly complicating acute decompensated heart failure also. And the challenges in this subset of acute decompensation heart failure is it's difficult to timely identification is difficult because these patients are in a chronically compensated low output state, and the manifestations of typical signs and symptoms are subtle. The other challenges, prognosis is poor, the short-term death rates are very high. The only benefit we have seen in the cardiogenic shock was the early revascularization of culprit lesion. Otherwise, no intervention till date have proven any, they have not given any survival benefit, not even the use of counterintuitively. I mean, intuitively, it will sound that mechanical circulatory support may increase, but we don't have studies. We think that they may help survival, but MCS improving survival, that is mechanical circulatory support, we are not very sure. And then there are concerns about MCS related, device related complications. And the issues, like why don't we have good results? Yeah, evidence of result, because patients come with advanced impairment. There is a risk of pre-selection bias. There are very obvious difficulties of conducting large RCTs and the complexity of disease. So these are the reasons why we are not getting perhaps good evidence about the use of MCS. But there is some observational evidence that a integrated shock team approach may reduce short-term mortality in these patients. So all these studies have strengthened the prognostic implication of early diagnosis, early adoption of mechanical circulatory support, and continuous and dynamic re-evaluation. This is most important, the continuous and dynamic re-evaluation of whether to upgrade, to wean, or to move to a palliation therapy. But we need more studies and standardized protocols. Now, looking at the historical evidence of Swan-Ganz shock, by previous speakers have talked about all the experience. So this is the evidence summary. The historically RCTs have not shown any benefit from use of pulmonary artery catheter. In fact, early data, Corners et al. And some other people showed risk of harm. The Pacman trial said that there's no change in in-hospital mortality, but it can be used safely perhaps, but gives no benefit. But the expert opinion and consensus was that it is perhaps probably better to use pulmonary artery catheter in really sick patient. And then evidence was there that it's an invasive procedure with where it may help in highly morbid complications. Pulmonary artery catheter definitely has the potential to change the management of a sick patient. Now, looking at non-invasive and minimally invasive monitors in cardiogenic shock, echocardiography, we all know it has some potential benefits like complementary role to invasive hemodynamic monitors. It can rapidly evaluate the structural and functional disturbances of heart. It can help us to start adequate and etiological treatments. So it's widely available and easy to handle. There are a lot of non-hemodynamic data and prognostic data, but the limitations is that for cardiogenic shock and it's a dynamically changing situation, we need continuous monitor. And whereas echocardiography is not a continuous monitor because we need to select our therapy promptly and we need to change it. Then echocardiography can be time consuming. There is a questionable reliability in the setting of cardiogenic shock because of rapid changes of patient's hemodynamics. And the ultrasound window may be poor, and then are fallacies in the cardiac output estimation. Minimally invasive techniques, they may be based on external calibration like PICO. It is come from the company Pulson. It is a pulmonary thermodilution technique. Then there is a lithium dilution cardiac output derivation. There are self-calibrating techniques like flow track from Edward. And there are some devices which need no calibration from Vigon. Limitation is, in spite of, initially these devices showed poor correlation with Swan-Ganz. But in time, in spite of technological improvement, the cardiac output estimation remains controversial and further studies are in progress. And the problem is these techniques are the estimation of cardiac output or there are the parameters which we derived or calculated parameters. These are not measured parameters. The only thing we measure is we estimate is cardiac output, and the cardiac output estimation is influenced by vascular impedance. It is less reliable in the unstable and dynamic setting of cardiogenic shock. Tachycardia, arrhythmias, and even mechanical circulatory devices may interfere. They are less reproducible. And transpulmonary thermodilution methods, in any case, will not allow us to discriminate between right and left heart dysfunction. And they will also not allow us to estimate the left filling pressure. The only advantage that these minimally invasive or non-invasive, especially minimally invasive devices can offer, that they can help us to track changes. But even this capability of tracking change has been questioned because we really don't know what we are tracking and in which direction we are tracking. So interestingly, there is a resurgence about the use regarding the use of Swan-Ganz. In any case, we have been, as discussed previously by my speaker, and we also talked that we use Swan-Ganz in the setting of cardiac surgery patient in OR. But slowly, with the heart failure patients coming to hospitals for treatment, the management of heart failure patient, for selection of devices, there is a Swan-Ganz is making a comeback, and this is what I'm going to talk a bit about. But we think, again, there not a lot of evidence is not there, but intuitively, Swan-Ganz monitoring in cardiogenic shock may be helpful when there is uncertainty about what diagnosis is there. It may be useful in more severe cases, which are unresponsive to the first therapeutic attempts. And Heart Failure Society of America in 2017, expert consensus was that invasive hemodynamic monitoring is helpful, and it should be done as a standard of care for the diagnosis and management of cardiovascular disease in these patients of heart failure. And the role of Swan-Ganz can be in, like, it can help us to diagnose and classify the cardiogenic shock. The cardiogenic shock is diagnosed as a combination of clinical signs and symptoms of low cardiac output, hypertension, of adequate intracranial volume. And most commonly, it is defined by the presence and persistence of systolic blood pressure below 90 millimeter of mercury, clinical and laboratory evidence like lactate elevation of tissue hypoperfusion, and the need for pharmacological or mechanical support to reverse the condition. We all know there are studies that clinically estimated hemodynamic profile is unreliable in more than 50% of times. So invasive evaluation of cardiac these patients by right heart catheterization remains the gold standard. And cardiogenic shock in numbers can be defined as cardiac index less than 2.2 liters per minute per meter body squares, associated with a pulmonary capillary wedge pressure of at least 15. Cardiogenic shock is an evolving and multifaceted hemodynamic scenario. And the sub-study of shock trial has demonstrated that from the relationship of pulmonary capillary wedge pressure and systemic vascular resistance, we can diagnose different types of cardiogenic shock, like most commonly wet and cold cardiogenic shock, where both SVR and PCWP are elevated. Then there is a dry and cold cardiogenic shock, which is characterized by hypoperfusion along with reduced filling pressure, or the filling pressure may be in the upper part of normal range. Then there is a mixed vasodilatory cardiogenic shock, where the compensatory increase in SVR is lost. Then interestingly, there is a emphasis on trying to diagnose a pre-shock or a non-hypotensive shock state. In these conditions, patients are in normotension or very small hypotension is there. They have a reactive tachycardia and some initial or very subtle sign of end organ hypoperfusion. And shock trial registry has shown that 5% of patient with systolic blood pressure of above 90 and who are not on any therapeutic support, but if we do a right heart catheterization, they will show similar PCWP and cardiac index as the cardiogenic shock patients. So these patients have a higher compensatory vasoconstrictive tone. But the problem is, if you don't treat them in time, these patients can have 43% short-term mortality. That is why it is important to diagnose these pre-shock and non-hypotensive shock patients. And we can diagnose this by help of Swan-Ganz. The Swan-Ganz can help us to evaluate the right ventricular dysfunction. It can help us to see whether the right ventricular dysfunction is present and how much the dysfunction is alone or in the combination of left-sided dysfunction. And 16% of these patients has RV failure as primary cause, where the short-term survival is similar to those patients which have predominantly left-sided failure, which may have a better admission profile. Then Swan-Ganz gives us hemodynamic predictors to identify a failing RV. If we look at, there are a lot of predictors. I'm just picking one. Pulmonary artery pulsatility index is the strongest indicator of RV failure and worse prognosis after MI. Honestly, my personal experience, I would like to clarify, is more with cardiac surgery in OR. We just last 4 or 5 years, we are using the Swan-Ganz to classify our heart failure patient for selection of devices. So our experience is still coming up. We don't have a lot of evidence from our institution and literature also. These are observational trials which are giving us these numbers. Then Swan-Ganz can help us to guide the pharmacological intervention and mechanical circulatory. I mean, it can help us to choose which mechanical circulatory device, whether to increase the support or to wean it. The accurate hemodynamic profiling can help us in better selection and dynamic titration of therapeutic interventions. And the observational trials in the heterogeneous population of cardiogenic shock has shown that if we use hemodynamic assessment in 60% patients, we can modify therapeutic interventions compared with clinical evaluation. And there's a trial by Mimos et al. Which shows that escape trial patients, if you use PAC, we are able to use higher rates of vasodilator therapy, and patients, when they are discharged at lower filling pressure, which may be better for them. Ultimate treatment goal in cardiogenic shock is to restore end organ perfusion without exacerbating the vicious cycle of increased myocardial oxygen demand and ischemia. Vasopressors and inotropics alone cannot do this, and they will be detrimental. There will be a detrimental effect on survival if the recovery is not soon, and we use higher doses of these inotropes. So that is why there is a pathophysiological rationale for use of MCS devices. They unload the heart, they provide end organ perfusion, and there is some evidence that they may be benefiting the survival. Then Swan-Ganz can help us assess the candidacy of whether to transplant or LVAD, because like the ISHLT has recommended that right heart catheterization is class 1 indication as a screening tool for candidacy assessment. And we need to evaluate the presence of pulmonary hypertension, its severity and reversibility before we go for organ heart transplant. Severe or irreversible pulmonary hypertension, we need to implant an LVAD as a bridge or as a destination. And then we can evaluate RV dysfunction using these well-validated predictors of post-implantation RV failure. And those predictors are pulmonary artery pulsatility index or an increased RAP to PCP ratio. Then Swan-Ganz can help us to prognosticate which patients we are going to the survival is going to be better. But yes, since device itself does not give any treatment, we use the derived hemodynamic data to decide which therapy is going to help our patients. And since the practices are not uniform, The large trials are not there. So we need to perhaps have some very standardized protocols and integrated shock team, and then we have to conduct our studies to prove the survival benefits. Swan-Ganz monitoring has been associated with better improval in survival chances in cardiogenic shock. But again, that is all from observational trials. Safety of Swan-Ganz monitoring, talking about it, we also talked that I told you that I have not seen any major life-threatening complication from my personal practice. And it is associated with only a small incidence of complications. Most frequent are related to the site of catheter insertion, that is puncture related, 3.6%. And they strictly depend on specific centers' experience and expertise. The rarely complications at heart block and pulmonary artery hemorrhage, they are very less. So I would like to conclude that cardiogenic shock is a very multifaceted and dynamic condition. It is associated with high short-term mortality despite therapeutic and technological improvement in recent years. The key to improving prognosis and survival probably lies in an integrated approach, timely diagnosis, the phenotyping, that is classification, using a shock team and a standardized protocol. And in all this scenario, the Swan-Ganz is being rediscovered as a valuable tool, and it may play a very important role to diagnose the cardiogenic shock, to classify it, to help us decide which therapy to use and when to wean from that therapy. But the only problem is very few studies have been published till date. And considering the intrinsic limitation of observational studies, we need prospective evidence to better clarify whether the theoretical usefulness of this diagnostic tool, Swan-Ganz, will help us achieving the yet unmet goal of improving the survival in these diseases. Thank you for attention.
Thank you very much, Dr. Chang. Today, the discussion in our meeting is very warm. It's already exceeded the time limit, but we still have more to say. So may I ask one question to you? There is one audience ask, have you ever met any severe complications related to PAC?
No, I think we were there when we talked about. I have not since 1995. I have been associated with high volume cardiac centers, where my personal use of Swan-Ganz and my colleagues, so our collective experience and moving ahead in our cardiac conferences in the subcontinent of India, I have not come across my personal collective experience, and from the conferences, I am not aware of any report or any. So I'm not speaking from the entire country. I'm saying there are no reported threatening to my knowledge.
Yes, thank you very much. May I share my screen? Because I do have a case just happened last month. I do have some pictures to show if I can. So now share my. Yeah. Okay.
It's at the middle. Yep.
How can I share my computer screen?
Okay, just give us a moment.
Yeah. Because
蒋老师，你看你中间有一排那个就是可以那个 control 的那些按键，然后有一个是一个箭头，你点那个箭头就可以 share 了。那个 David 的群里面分享那个。
Yeah, I put it in the chat group. Yeah.
Yeah, okay. 能看到我的屏幕吗？
没有，
还没
有看不到，
还不可以是吧？是。
I think you need to select which screen you want to share at the bottom. 下面那边有三四个荧幕这样子。
Yes. Okay. There's any.
要不您发给我们也行，我们 share 现在感觉
it's
很
a
快。
large, it's a large.
A large file. Oh, okay.
So sorry,
Oh.
that's fine. Okay, forgot it. So last month I met a PAC just not in the super SVC, yes, superior vena cava. Get a note in that. Yeah, it's the last month. So a couple of years before, we do have one case because the physician forgot to deflate the balloon, so it makes the pulmonary artery damage and bleeding. So we have to ask the thoracic surgeon to do the lobectomy during the bypass. You know, it's a very bad story. So we do have that kind of two complications.
So we occasionally we see knotting.
Yeah.
But knotting doesn't hurt us because when we pull the Swan-Ganz, it comes out of the heart only at the level of neck. So sometimes our cardiologist, we go to cath lab and unknot the catheter, or the worst come worse, we just pull it and put the pressure here. It usually, but most often time I don't recall pulling any time. We just have go to cath lab, and some patients when we unknot with the help of catheter and cardiologist with guide wires, we are able to unknot and we remove them. So knotting is not that uncommon, but it is again knotting is not shown to be dangerous. So we are able to overcome.
It's not dangerous.
It's a distressing inconvenience.
Yes. Thank you. Thank you very much. Thank you for your experience and the presentation. Thank you.
PAC knotting is a rare but could be a disaster complications.
Yes,
if you are interested, you can search PubMed. There are a lot of cases reported. The key to prevent this complication is do not insert PAC too deep. If you cannot get the corresponding pressure wave or pressure values.
Okay, thank you very much. Thank you. So,
okay.
I think I have one comment. Sorry. Yeah, Dr. Rajesh, thanks for sharing that. That's a very interesting sharing. I think I may have something, I'm not too sure how valuable it is, but I may have a paper to share with everyone with regards to Swan use in cardiogenic shock. It's a recent paper in 2020. I'll share with everyone. I'll email to you all. So basically, long story short, it's a retrospective study, 1,000 patients. They kind of showed that the more you assess, the more parameters you assess with Swan-Ganz, the less the mortality. But in the interest of time, I'll just leave it as it is. Yeah. Thanks for sharing. Yeah.
No, I agree with you, David. For preparing my talk, you remember I told you that I was skeptical about what to talk about right ventricular function. You remember that?
Yeah.
When